let me put something else on the table. Let's take a look not at the cost for a single course of any antibiotic, fidaxin is one, fidaxomicin, but don't you have to look at the whole global picture? In other words, if you've got a more expensive drug, but the recurrence rate is lower, so the total cost of this disease to the system, to that patient, may be lower, don't they take that into consideration at all?
Well, again, it depends who's paying the bills. So
well, even if somebody is paying the bill at the hospital, couldn't you say, look, the recurrence rate is lower, they're going to come back in, they're going to require more therapy, it's going to be more expensive. If we do it right the first time, then it's going to be cheaper in the long run.
We actually know that that's true.
So why don't they listen?
There's modeling that shows that, and there's actually now emerging real-world cost data showing that that's true. But if you're a pharmacy manager in the hospital, and you get to pay $2,000 for a drug that's going to save the insurance company outpatient costs when the patient recurs, that's a difficult equation to justify.
So we've got a silo issue.
Yes.
Yeah.
And we've seen this in lots of other portions of the healthcare spectrum, which is to say, my bill's here, your bill's here, and never the twain shall cooperate.
Right.
But I think that the silo is largely conceptual and not realistic. And I'll tell you why. What Darrell is saying is that why would a hospital invest money for payers than to save money or for society to save money? But now hospitals are measured by how much C. diff they have, and a lot of the C. diff that they have is actually the result of recurrence. You have to remember that every time you have a patient with recurrent C. diff in your hospital, there are secondary cases. So it produces more C. diff in the hospital. Many of those patients get readmitted within 30 days. And I think if hospitals really looked even into their economics in details, they would find that it's an investment worth doing.
I don't want to lose what you just said. Readmitted within 30 days, they don't get compensated.
Well, right now they do get compensated for readmissions unless it's for one of several initial admissions but this is going to be further expanded by CMS and so forth. And there is a comparison of hospitals that's put on the public domain as to what you're going to a hospital to have removal of your gallbladder or cataract surgery, how likely you are to get C. diff, and that's a reputation, and there is a reputation cost to hospitals. I must say that we use, you were thinking maybe 30% of our use of fidaxomicin is high, is low. I would argue that it's probably among the highest that I've ever heard.
Agree with that.
And every year, and we are sensitive to economics as well, but what we find is that we only have to give patients 3 or 4 days on the average of treatment. The rest they get in an outpatient pharmacy. So we're not making the investment for the entire course.
So that's somebody else's silo again.
And very often the outpatient pharmacy is our own hospital pharmacy. And so at the end of the day, we found that we're actually not losing any money over providing the best care for our patients.
Yeah, you're right. I was surprised that 30% was low. I mean, call me naive. Many people do. But I hear we have a drug that works, it works better, the recurrence rate is lower, it's simple to give. Why don't we use it? And the answer, whenever I ask that kind of a question, always comes back to dollars and cents.
And the other part of that answer is it's not our decision, always.
Okay.
It's the hospital P&T committee, or it's the outpatient prescription carrier. That probably more often than not, if I try to prescribe fidaxomicin, it's denied by the insurance saying I have to try metronidazole or vancomycin first.
He says don't do that.
Well, new guidelines hopefully will change insurance company practice.
Well, it'll be interesting to see with the new guideline what insurers and third-party payers do with the metronidazole treatment recommendation, because that has been sort of the basis of coverage for C. diff, is that you needed to try metronidazole first.
But isn't that, it's an example of the medical philosophy of, for every complicated problem, there's a straightforward, inexpensive, logical solution that's just wrong.
Right. but I think that the situation in which metronidazole may be the only available drug is kind of declining and disappearing now. Yeah. There are new preparations of vancomycin, particularly one that's called the First, which is not going to be more expensive than $150 for the entire course. So and this is available. So I think that there will be little excuse to be using metronidazole as first line anymore.
The other point we should make for the audience is, for outpatients who are having trouble paying for the copay, there are patient assistance programs that can make it almost free.
Okay.